Good evening, everyone. Thanks for joining us and welcome to this special live webinar on challenging cataract and glaucoma cases. Thanks to Sotema, this is a big Moroccan laboratory, for his valuable support. I am pleased to welcome all our experts, speakers, and panelists from 10 countries around the world. Great to be with all of you today. I would like to thank my friend Ashraf Armia for his involvement in the organization of this webinar. He is a consultant cataract and refractive surgeon, anterior segment reconstruction in Cairo, Egypt. Thank you, Ashraf. I call Ashraf to start this webinar, to open this webinar.
Thank you, Sidi, and welcome to everyone. I am pleased to moderate the cataract session with Dr. Sidi. He's going to moderate the glaucoma session. We are now live for everyone. We have registration for more than 1,000, I think now. So everyone is watching us now on YouTube live. So we are going to start the cataract session. The videos, it's like a show. We are just going to start the videos, and we are going to have some questions related to the video and some discussion about the decision making, why he chose or she chose this way in dealing the case. Okay, so it's my pleasure to give the talk first to Dr. Detlev Breyer from Germany. I'm so happy that he joined us today. He's going to present a very interesting case. He giving the topic is hunting for the best in refractive lens exchange. Can you share your screen, Dr. Breyer?
And thank you very much for having me. It's a real pleasure that you invited me to this very interesting session. So, and when you called me, I was still in bed and I saw your messaging and you asked me for complications in cataract surgery. And then I was thinking about the complications all of us have as cataract refractive surgeons. That means unhappy patients. And we have to explant multifocal IOLs again because there was not the right selection of IOL. So this was bothering me for many years, and surely not only me, but a lot of our colleagues. Those spend a lot of chair time or explanting multifocal IOLs. So I hope this video, which was awarded at the ECRS meeting, is not known to everybody of you. I'm not going to bore you. So we will start the video right now. So, okay. And do you see the video? Can we start it?
No, we can see the video now. Not yet.
Not yet.
Binocular.
Sorry.
Ja, aber vorhin hat das auch noch funktioniert. Hat der Moderator eine Freigabe gemacht, das Video.
Okay. This was one of my challenging cases when a hunter came to see me and he wanted to have multifocal vision. But as we all know, kannst du es nicht abspielen?
Ja, okay, gut.
As we all know, hunters, they have to hunt in dusk and dawn. That means they don't like loss of contrast sensitivity. So you can't give them
binocular vision
lenses.
with segmental multifocal intraocular lenses by Detlev Breyer, Hakan Kaymak, Karsten Klabe, Philipp Hagen, Florian Kretz, and Gerd Auffahrt. Why do we need a new MIOL formula? The disadvantages of bifocal IOL, such as halo and glare, and no clear intermediate vision, caused 4% unhappy patients and 1% explantations. In contrast to that, The features of trifocal IOL are less halo and glare and clear intermediate vision. But these are accompanied by some disadvantages, such as less contrast sensitivity and reading only in good lighting conditions. Anyway, the patient acceptance of trifocal IOL is higher since clear intermediate vision and less halo and glare are crucial for many patients. In 2013, Dr. Breyer moderated the Asia-Pacific Association of Cataract and Refractive Surgeons in Singapore, where Dan Reinstein presented his presbeyond laser blended vision concept as an innovative treatment of presbyopia. Here, the dominant eye is corrected for distance vision to almost plano, whereas the non-dominant eye is corrected to be slightly myopic for near vision to minus 1.5 diopters, with a spherical optic resulting in a blend zone of vision. This inspired us to adopt the concept with segmental MIOL for extended depth of focus as a new treatment option for presbyopia and cataracts. We developed a new formula that offers comfort immetropic vision or comfort blended vision according to the individual patient's needs with Lentis Comfort and Lentis M+X. And this is how it works. Near additions and target refractions are combined in different variants. As a tribute to our hometown, we called it the Düsseldorf formula. To achieve comfort immetropic vision, we implanted Lentis Comfort in both eyes with emmetropia as target refraction. For comfort blended vision, we choose Lentis Comfort with a near addition, for example, minus 1.5 diopters in the non-dominant eye, or comfort M+X with the Lentis M+X in the non-dominant eye, according to the individual patient's needs. In 2014, we presented our new formula at ISOP and ESCRS in London. Defocus curves generated from clinical data and the knowledge of multifocal MIOL capacities are indispensable in meeting patients' differing needs. 1 year later, at the next meetings in Barcelona, we presented our first clinically significant scientific results. The strength of halo and glare was defined as the geometric mean of size and intensity and subdivided into 4 categories: none, mild, moderate, and severe. We could show that the Düsseldorf formula demonstrated excellent visual results in far, intermediate, and near, with very few photopic phenomena comparable to our employees aged between 16 and 60. In 2016, at the German meeting of cataract and refractive surgeons in Mannheim, and at a congress of the University of Heidelberg, we presented our latest findings. In the cause of our quality management with MIOL, we investigated the influence of the optical design, near addition, and target refraction of MIOL on photopic phenomena. The results confirmed our expectations. In diffractive optics, higher near addition and deviation from emmetropia correspond with stronger halo and glare. Refractive optics overall have higher tolerance regarding photopic phenomena compared to diffractive IOL. Preoperative evaluation. True corneal shape analysis and measurement of total corneal astigmatism with the LED Cassini. Examination with a corneal aberrometer. Surgery. The corneal refractive information of the Cassini is wirelessly sent to the laser. The iris registration enables us to find the true axis of astigmatism and mark it with the laser. This video shows the implantation of the Oculentis Comfort Toric MF15. Alignment of the toric IOL markings and the corneal marks for perfect IOL orientation. One month after the second surgery.
So hello, Mrs. Hall. Now we have 1 month after surgery. You did have a little time to get used to the new vision, I hope. Are you happy with the result?
Very happy.
Very happy, that sounds good. So very happy means that your far vision, intermediate vision, and near vision is fine, despite small print reading. Is that correct?
Yes, absolutely correct.
Where would you think or find yourself? In the maximum, medium, or minimum?
Medium.
Medium, okay, perfect. Okay, dann kann man das stoppen. Okay, I hope that was a little bit as interesting for everybody, or at least one.
So, thank you so much for your presentation. Do you hear me?
Yes, I can hear you perfectly.
Yeah, thank you so much for your presentation, Detlef. So you think that refractive lens exchange is a good option when you use a multifocal or trifocal IOL?
Yes, I do, but I think you clearly, and I wanted to make it understandable with a video, you have to talk to the patient and individualize multifocal IOL surgery. Because if you do the Düsseldorf formula, you will not be able to read small print, but you have nearly no halo and glare. But there are also people who say, okay, photopic phenomena, it's not a problem, but I want to read small print. So the most important thing is a visual history of our patients, and then we adapt the lenses. And what is also a little bit nice with the Düsseldorf formula, you can still, if the patient says, I want to have a little bit more far or near vision, if you are further away from emetropia or your target refraction, you can still do a touch-up procedure with laser vision correction. So it makes it easy to correct this even later on. In contrast, if somebody doesn't like a diffractive trifocal lens, that's it. If he doesn't get around with halo and glare and vexy vision, he has a problem. And here you can still adjust later on, even with a touch-up procedure.
What do you think about very focal LASIK surgery or multifocal?
I personally, I'm a really big fan of Presbeyond laser vision correction, and I just bought a Schwind laser because I also think the Presbymax is a very interesting, good idea. And I do like solutions. If the patient wouldn't be happy, you can go back to zero with easy surgery. I think you always have the possibility of a way out if the patient is unhappy, because sometimes you lose the patients, they come back after 6 months, another doctor has done capsulotomy, and somebody implanted a trifocal IOL, and then you have to explant it. And that's no fun.
So did you stop implanting diffractive IOL?
No. Because, as I said before, I really think there are enough patients, and for example, let's take my population. I implant 90% EDOF or trifocal IOLs, and 40% of them want trifocal IOLs, even they know they have photopic phenomena. They just don't care about it. So everybody of us is different. He has a different hobby, different business duties. So I think what we have to do as doctors, listen to our patients and then adapt the refractive IOL-based laser surgery to their needs, and always put the disadvantages in front. So what I tell my patients first are the disadvantages of what I'm going to do. And then I look at their faces. If they're like, oh, I don't like it, then I don't do it.
What about corneal halos? Or the corneal abrasion before you implant a diffractive or multifocal IOL? Do you?
I don't want to have it above 0.3. That's for me, is it? I don't care to do after LASIK procedure trifocal IOL. If the aberrations are not above 0.3, I think it's not a problem. If you have a nice optical zone, I do that and have a lot of happy patients. Just yesterday there was one. And a very good friend of mine, she came from Munich, same thing. Many doctors said, "Oh, no, you can't implant." I said, "Yes, why? You don't only have 0.2 corneal aberrations." Then I implant a trifocal eye.
Thank you so much, Detlef. Sure, there is a lot of questions. You are going to be with us till you go to your operation. Thank you so much.
Thank you.
Can I comment a little here?
Yes, Lucan. Yes, you have.
Regarding the Düsseldorf formula, I think it's a perfect way to approach the patient needs. In my practice, we also used a lot of oculentis IOLs, and we find that, as stated in the video, M+X combined with lentis comfort is a little bit, there are the intermediate vision somehow is not really good. We used to, when we have hyperopic patients, we combine M+X with MF20, but we really pay attention to the angle kappa or the visual axis, because M+X is really sensitive about that, and vice versa. In myopic patients, we tend to go with 2 M+X IOLs because they are really good in near vision, and frankly, the myopes are not care so much for their far vision. What are your observations, Dr. Breyer, about that?
I'm absolutely with you what you're saying. We just stopped the M+X due to the reason because I think some of them, they have a really high coma as photopic phenomena. So then I love to combine, for example, in the dominant eye, the LARA, which is the EDOF diffractive, within the non-dominant eye, the trifocal LISA. Because those phenomena, to me, seem a little bit more calculable, like the M+X. But when I'm traveling through the world and I'm talking to different distributors, it's really interesting how in one country the M+X is the best and it is planted like a monofocal, and in other countries it's not accepted. This is very funny. I can't really tell you why, but what you said about the angle kappa, how to deal with it, and about the myopes, I completely agree. I just personally don't get around with the M+X, then I prefer diffractive. But that's my personal thing. This has nothing to do with another country, just my personal experience with my patients.
Thank you so much. So now we are going to move to another very interesting topic by Dr. Nancy Rakkad from Jordan. I'm going to choose this now. She's going to tell us about small eyes. It's a big problem in cataract. You must think twice. Dr. Nancy, can you be with us?
Yes, thank you, Ashraf, for the presentation. I will be talking about cataract surgery in nanophthalmic eyes. And I think we're moving from a very broad spectrum. You moved us, Ashraf, from multifocal premium surgery to this procedure. Through the video, you will see how straightforward it would look to the viewers. But allow me to comment through the video on how we faced obstacles until we came out with the best outcome. So I had 3 siblings, 6 eyes, with a nanophthalmos eye. The axial length was 13 in all of them. So you can imagine you could just poke the eye with a very trivial punch. The corneal diameter was 9 millimeter, as you can see, and the intraocular power was 62 in one eye and 60 in the other eye. We discussed with the patient the refractive outcome because IOL power calculation is never predictable. We also discussed the risks because this is a very small eye. As you can see, I poke the eye in order to be able to reach it. My tip of finger is larger than the globe, if you can see. And we proceeded with the Phaco. The patient took mannitol and Diamox before surgery in order to decrease the pressure coming from the vitreous. And then we proceeded with the surgery. I'm not going to say a lot. I just want a video, although we were on our nerves during the procedure. I tend to do my rexes on the small something happens, I always use the anterior capsule, which is sufficient enough. So this is a small rexus that I used to perform. And because he's young, aspiration was just so easy. His vision was counting finger 3 meters, by the way. So I just aspirated the lens. And this was the first eye of the 6 eyes I've done. And I learned something before. So in the next eyes, not to remove my 2 instruments or 2 hands from the AC and allow it so quickly like this. So this is something I wouldn't do again. Inject a lot of viscoelastic before you draw your second instrument or your second piece of instrument you're using inside the eye. So yeah, I'm doing this again, but I was saved by a lot of prayers. I was quick, so not to allow any complications to happen. And there's a very big list of complications that would happen with these patients. Please ask me about it when we finish, Ashraf. So this is the lens. It's a very customizable lens. It's a CT Extreme D from Carl Zeiss. And it's a very thick lens. You can see me struggling in tucking it in the injector. And I want to show you without editing how we struggled to tuck it in. And you see 3 loops, and it's not a multifocal lens, it's only a monofocal lens, but because it has a very high power, it is incremented in 3 loops. And it's only a 6 millimeter in diameter. You can see it's half almost half the normal IOL, or the usual IOL. And one trick, inject it slowly outside a little bit because it's very thick. It gets stuck in the injector. So you have to use a lot of viscoelastic and try it fully because the rate of posterior capsular rupture is high in these patients. I inject half of it in the bag, and the other half I tuck it in with my Sinski hook. It's a thick, small lens. And voila. This is an uncomplicated surgery with lots of preparation, lots of prayers, lots of struggling, lots of patient counseling, and lots of things to learn about how close to being complicated these eyes are. And thank you.
Thank you so much, Nancy. This is a very interesting case, but I have a lot of questions, really. This type of lens, what is the size of your anterior rexus you are going to do?
The size of the rexus is 5 to 5.5 millimeter. The eye is small, The cornea diameter is 9, so tend to do a smaller rexus than usual for many reasons. The first thing is that you don't have to, it's still in front of your eye. It doesn't tear out whatsoever, especially that these are young patients. The second thing is that the lens is a small lens, and so you capture it with having the size of the rexus covering it all over. And even if you have like a posterior push from the vitreous, having a small rexus with the lens, even if you put a heel on heavy heel on or an OVD inside, you can push the vitreous in a good way during the surgery.
Another question: why you choose this procedure? Why you didn't do a piggyback IOL? Because if you post-operative, if you have a refractive surprise, you can remove the second IOL and you can change it, because this is one IOL. Also, why you didn't do a posterior rexus with anterior vitrectomy, and you did a capture of the first lens away in the like a posterior capture?
Okay, so I'll start from the last question. Now, these patients are at a very high risk of having malignant glaucoma. So one of the recommendations is to do a limited anterior posterior vitrectomy. The instruments were not available at the time, and I felt safe giving mannitol and Diamox before surgery. So I was playing it safe, although I had that in mind in subsequent procedure, but I never had to use it on all the 6 eyes. This is one thing. The other thing, but if you're happy, the second thing is piggybacking. This eye is very small, that the axial length is 13, and the AC depth is 2.2. There's no way I could piggyback, put a lens or and add a lens afterwards. I would do this in eyes with 35, 36 diopter IOLs with an axial length of 18, 20. I would think of this. And we had a patient like a few days ago who had a 40 diopter IOL. We inserted the 35 diopter lens and left the rest to do something about it when she comes next week for a refraction. We either do a LASIK surface ablation to accommodate the residual error, or a piggyback IOL. But an eye like this with a 13 millimeter all in all, I wouldn't think, except of the CT Extreme from Zeiss.
And which formula you used when you choose the IOL power in these very small eyes?
Yeah, IOL formulas are very unpredictable in nanophthalmic eyes. They're not only microphthalmic, they are nanophthalmic. And you have to be able to discuss with the patient that there would be a possibility of a refractive outcome, a surprise or a problem. So what I prefer to do is take more than one formula, more than one measurement, and compare them. Now, the best till now is the Barrett 2 universal formula that gives you the best predictive outcome with a very low margin of error of 0.2, only 0.2 margin of error. The other formulas, which is the best in a row, comes the Hagees formula and the Hofer-Q, but they give you a wide margin of error, actually up to 0.6. So, but all in all, never use the traditional SRK2 or SRKT. They do the worst in these very short eyes.
Thank you, Nancy, so much. I'm going to move now to the glaucoma session moderated by CD. He's going to present 2 cases. So the wave with you now, CD.
Next speaker is Alain Bron from France. Do you hear me, Alain Bron?
Yeah, yes, I see you. Thank you for inviting me. I'm very happy.
You will, Alain is going to share with us a video on landmarks in deep sclerectomy. Very interesting video, I'm sure.
Thank you.
I'm sure of that.
Shukran. Shukran. So I'm going to share my screen, and here in Zoom. Okay. Voila. I think now you have my screen. Am I correct? Okay, thank you. So even for experienced surgeons, we need landmark when we are doing surgery, whatever surgery. I did refractive surgery when I was younger. It's exactly the same. And that's my disclosure statement. And sometimes I found this cartoon for you, my friends. You can be lost in the desert or elsewhere. And when you are dissecting your different planes during your surgery, again, even though you have a strong experience, you can be lost. So you need some flags, you need landmarks which cannot be contested. You need to be sure where you are. And for glaucoma surgery, whatever the surgery, it could be deep sclerectomy, it could be trabeculectomy, viscocanalostomy, your best friend is the scleral spur. And let's see a video of a video running well, I would say. So personally, I've been taught by my Swiss friends and colleagues, André Mermou, Gordana, Tarek, and that's the dissection of the first flap. You know that I'm doing the surgery most often under topical surgery with a xylocaine injection. And you have to find the good planes of dissection. And when you are in the good plans, it's okay. It's when your GPS is working, you know, you go directly to the right address. And here, the main landmark is this white. You know, this white is very special. It's the white of the scleral spur. It's like the white in a pearl. It's different from the other white of the sclera because you have no pigment inside. That's the dissection of the second flap, which is for beginners difficult, but here you can see the difference in the color. When you see this gray color, you can be sure to be deep. On here, you can see this bright white. I guess you can see it, pardon me, here. It's very obvious. And this is the scleral spur. So like that, you can go anteriorly. It's exactly the same planes that corneal surgeons are using for the new surgery, like the AEK, the MEK. And here, the last landmark is the removal of this small layer, 15, 20 microns with special forceps, Dumont number 5, which is the trabeculum, the cribriform trabeculum or juxtacanalicular meshwork, which offers 80% resistant to aqueous outflow. And like André taught me, you need to perform a large window. But of course, we are showing the best case like plasticians, but unfortunately, it's not always like that. This is another video. I'm doing the surgery. It's not a resident. And this day, I don't know why, patient difficult, I was not in good shape. I have some difficulties to know really where I am. And I'm a bit anxious about this. You can see here, I see a radial vessel. You can see the red of the radial vessel. It's a high magnification, so of course it's very moving. And here, what I thought it was the beginning of the cornea, but actually not at all. It's the ciliary body, as you can see here. So I have opened the sclera. I'm within the uvea. It's very bad situation. And in this case, I try to find where is my good friend, and my good friend, again, is the scleral spur. And you have to imagine the scleral spur as a sort of ring, you know. In the past, I did also some keratoplasties, and we were using steel rings around the eye to maintain the shape. It's exactly here. Unfortunately, I was able to find the scleral spur here, and now I could clearly see here the juxtacanalicular meshwork. You can really see it here. I hope you are seeing, generally speaking, Zoom is pretty good for videos. And with a special forceps, I was using the Rifay knife, which was taught to me by André Mermou as well, to have a smooth dissection, very anterior, because if you have to do further goniopuncture, it's much easier without incarceration of the iris. And you can see the percolation of aqueous humor through the cornea. You can see here the vessel very clearly. you can see the effraction within the uvea, but which is not damageful to the patient. Here, unfortunately, I have damaged partly the scleral spur, and at the end, I'm removing the juxtacanalicular meshwork, which is really the success of deep sclerectomy. Otherwise, it does not work. So that was 2 short videos to tell you that when you are doing surgery, you need to be in the good plan. It's true, but again, if you want to know, it's like on the road. Sometimes your GPS is going wrong and you don't know where you are. So only the scleral spur can tell you what you are. And it's exactly the, I have added two slides just to end my presentation. You need to consider the anatomy of the angle from inside. We are used to that when we are performing gonioscopy. And to see exactly where you are, because some angles are difficult, you have to rely on this small white band, which is a special bright white, which is a scleral spur. You can see here this pigmentary angle. Here you have precisely the scleral spur. It's from inside, but you have to consider the same anatomy outside. And here I have chosen a patient with an embryon toxon. You remember that the embryon toxon is an exaggeration of the Schwalb's line. So it's the anterior limit of the trabeculum, which is approximately here in the scheme, here in on a live eye. And here you have the white, pardon me, the repetition, but this bright white is very useful because, again, you know where you are. In front of the scleral spur, you have the trabeculum, and in this case, the juxtacanalicular meshwork you have to remove. Here the trabeculum, and here the Schwalbe line. So to conclude, if you want to operate properly, you need to know the anatomy, the 3D anatomy, and also your good friends, and like that you can rescue a surgery which was really at the beginning really bad. Thank you for your attention.
Thank you very much, Alain, for this nice videos. The landmarks in deep sclerectomy is the scleral spur is a very important landmark for this surgery. I would like to ask you about this dissection. When we the level of the dissection is you miss the Schlemm's canal. What do? You dissect a third flap, or you go directly to the Schlemm's canal?
Yes, because otherwise, if you are not too deep, it will not work. So in this case, you have to dissect a third flap. I have also a video for that, but it's much more difficult and you have more risk to perforate. That's why you have to rely on the deepness of the second flap, yes, to rely on the gray. I try to show you the nature of the gray, and when the sclera is much gray, that the more superficial sclera, you are in the good plane. It's the main mistake for beginners. Beginners are shy, of course, because they are afraid of perforating. But if it does occur, of course, you need to do a third flap. Yeah.
Yes, of course, the second flap must remove 90% of the thickness of the sclera and let only some fibers of sclera there. And in the case if a small perforation, what do? You convert your deep sclerectomy, your trabeculectomy, or you continue your surgery as usual?
It depends on the magnitude of the perforation. If you have, for instance, it occurs mainly when you are performing combined surgery with cataract surgery, because in this case, with the pressure within the anterior chamber, you can have, we'll see, a strong extrusion of the iris. in this case, it's very difficult, it's very boring situation. However, when you have a small perforation without incarceration of the iris, you continue the surgery, and you should remove the juxtacanalicular meshwork. So it works only in small perforation, but when the perforation is too obvious, too wide, you need to remove an anterior part of the cornea, like in, I would say, trabeculectomy, and to do an iridectomy, because otherwise the iris will come directly in the site of your pseudo-trabeculectomy, and you will have an obstruction. And most often, people say that you can remove the iris with laser, but in my end, it does not work. You have to do that immediately on the table. But it's really a worrisome situation, because in those cases of conversion, the results are not as good as, I would say, first-hand trabeculectomy. I think my good friend, Dr. Agoumi from Canada, maybe I would like to comment, or Mohammed would like to comment as well on perforation, which is a tricky situation.
Of the Schlemm canal, do you always peel the Schlemm canal, or is it depends on the percolating of the aqueous humor? It's what do you do? It's mandatory to peel the juxtacanalicular Schlemm canal, or it's not mandatory.
You know, which is interesting in peeling of the juxtacanalicular meshwork is that this meshwork was described as Andersbill in 1974. So well before the description, the final description of deep sclerectomy, because it's the part of the trabeculum which offers 80% of resistance to aqueous humor. I'm used to say to the patient or to the students, it's like a filter for coffee, but nowadays they only consider espresso, so they don't understand, the young generation. But the old generation can understand. If you are always using the same filter to do your coffee, one day you will not filter it anymore. It's exactly what happens to the trabeculum. Yeah. So the magic of this surgery is that you're removing 80% of the thickness, and this has been described before by a great physiologist, Andersbill, 30 years ago, or at least 10 years before the advent. So if you don't remove this part of the trabeculum, it will not work. And when the surgeons say percolating, when it percolates too much, they are perforating.
Yes, I agree with you. Yes.
On videos, it could happen when you are live, yes, because you have some emotion. You know, I was used to operate in Marrakesh. I was not in my usual feet yeah, or shoes. Yeah, yeah. Yes. But it's true that it's different. But percolating maybe, but not too much. Yeah. What is your opinion on that?
But for my opinion, mine.
Yeah.
Yes, I peel always the juxtacanalicular trabecular meshwork. Yes, yeah, of course. But I add always, almost always, or almost the trabeculotomy of the Schlemm canal. I perforate at the end that improve the drainage of aqueous humor and allows me to obtain a higher bleb and a higher filtration with deep sclerectomy. I showed that before. You have seen that.
Do not advise that, because you may have something, I would say, sticking, the iris is sticking very rapidly. It could happen, but if you perforate very anteriorly, why not? But right, I don't think it's mandatory, but as you know, it's like...
Yes, it's not...
Each has his own recipe, and I do respect your way of having this kind of surgery.
Okay.
So, Alain?
Yes?
I would like to greet you. Professor Alamon.
Yeah, yes, I see you. Oh, nice to see you.
Nice to meet you. Thank you for the presentation. Just I would like really also to comment that the problem here that the deep sclerectomy is not that much popular in our region, maybe because of that we don't know the landmarks. So this is really mandatory. If we don't know the landmarks, we are lost totally. And the question of Dr. Ezzouhairi, I would like to ask it as well, because I know that some well-known also named surgeons, they used to perforate at the end of their deep sclerectomy. Maybe it's not my practice, me myself, but they used to do it in like for each patient. So I think so it has to, I don't know how they are doing it exactly. It has to be in the periphery, it has to be in the center. So I don't know if you can comment on this question. I had also the same question of Dr. Ezzouhairi.
But Mohamed is doing, maybe Mohamed is better qualified than me. Personally, I don't think you need, because when you consider the physiology of this surgery, which is based on I would say, on the physiology, I mentioned Anders Bill in Uppsala when he did that. But for instance, another option has been proposed as a laser. You don't need an expensive laser to destroy that, because it's expensive. You need to remove it. Remember, you have to keep in mind the image of the coffee filter. So that's it. But the problem is that in some patients, it's true that we cannot do that properly. Because personally, I'm operating on topical surgery with lidocaine infiltration in the conjunctiva. This morning, I could operate a patient. He was 86 years old, but he was completely deaf. He could not understand what I was telling him, and he had a very flat position of the eye. He was not looking down, as you know, Schuffeltat, you know, and with my terrible accent. So it was difficult, so I did a poor peeling. But again, we should respect what other surgeons are doing, because in the case of Mohammed, it's really based on his personal experience, so I trust him.
Still, I have a question, Professor. As you said, the peeling is important for the juxtacanalicular measure, but at the same time, the anterior connection between the anterior chamber, we have to be so anterior also as well. And to cut the second flap, this for me, maybe the challenge, for me myself, this is the challenge, to cut the second flap, because if it's the flap is a little bit thick, it will cover all my axis. So I don't know how your practice, you are using the knife, you are using the scissor to cut it?
Well, as I told you, I'm a pupil of André Mermoux. And André Mermoux was one of the pioneers of deep sclerectomy. And we were taught by André that we should be very anterior. I would say it's the same for trabeculectomy. When we are doing a trabeculectomy, removing the trabeculum or not is not the problem. As it was said by John Keynes, it's a guarded filtration. You have a fistula between the anterior chamber and the subconjunctival space. Because if you are too posterior, you are damaging your landmark, so the scleral spur, and you will have a cyclodialysis. So you need to be anterior, but it's very difficult, and you have to find the good instrument. In the old days, I had the ruby knife, but they were broken, and now I'm using you have seen this very smooth knife, which is a beaver from Becton Dickinson, and the price is €1. So it's very cheap, but maybe some of my colleagues are using very sharp knives, which to me it's too dangerous. But again, it's like in recipe, you know, when you are doing the tagine, you have your own tagine on your own pastilla or your own corne de gazelle.
So, just I remind that deep sclerectomy is requires an open angle, only in open angle. It's very important. So we move to the next speaker. Thank you very much, Alan. We move to the next speaker, Younes from Montreal. Younes Agoumi is going to talk about exam complications. Thank you very much for joining us in this webinar.
You hear me?
Yes.
Okay,
You can
thanks
share
a lot.
your screen.
First, I want to thank the organizers for the very kind invitation. I'm going to share with you my screen. You see the video. So Xen surgery is considered as a hybrid surgery, actually, between traditional glaucoma surgeries and MIGS regarding efficacy and also regarding complication rates. I did more than 200 Xens in the last couple of years, and I have to say it's a very safe surgery. But this video demonstrates what can go wrong with Xen insertion. The key in Xen insertion is really to make sure that the Xen is placed in the subconch space. You really want to push the needle through the tenon, just under the conjunctiva, and the needle will be pointing up, touching the conch. It almost looks like it's going to perforate, but most of the time it doesn't. In this patient, he wasn't collaborative, and he was moving a lot. He had some cognitive issues. So it went through the conjunctiva. You just have to grab the tube and very gently to put it actually into the inserter again. And then you can put it close to the first location, and you don't have to close the bottom hole in the conch. Also, another complication that can happen, the subconch heat. This is one reason why I always inject the mitral under the microscope to avoid the vessels. Usually I enter at 12 o'clock position, aiming towards the supernasal quadrant, but here I had to adapt actually to the bleeding. Heme is a sign of bad prognosis, as you know, because it induces fibrosis. Another important point is that you really need to push the slider completely to the end before removing the injector from the angle. So the needle is retracting into the cannula when you push the slider. And here the needle wasn't fully retracted. You're going to see the bevel. You can still see the bevel here. And the Xen will be pulled back into the anterior chamber. So in this case, again, you go with microforceps and you retrieve the Xen very gently. When you come out or you remove the injector from the angle, you also need to relax your hands to avoid the flicking movement. So the flicking movement can lead to pulling or even cutting the Xen during your surgery. Here, in this case, the hand was relaxed enough to avoid the flicking of the needle. The best way to avoid needling is really by making sure that the implant is free and mobile at the end of your surgeries, and also that you have a good flow in the OR. So I always check the flow and that I have a nice lab at the end of the surgery. If during the procedure you're not happy and there's any doubt regarding positioning of the Xen, like in this case, it was short in its intraocular side, it is best to reposition at the same sitting. The stent is very fragile again, so use non-tooth forceps over the conjunctiva, very close to the sclera, and push it into the interior chamber. In this case, I just wanted to show you actually how easy sometimes the tube can migrate into the anterior chamber in very myopic patients. So it's important to have a long intrascleral path of at least 3 millimeters in high myopes. You can still manipulate the tube during the first 24 hours. After that, the tube hydrates and expands. One important reason why I never had any cause of any case of endophthalmitis is that I removed the tubes with impending extrusions. If I see that the conch is very thin, avascular, and the bleb is flat even after a needling, I tend to remove the Xen and close the sclera. This aesthetic bleb can be also a problem. At my first cases, I started actually putting the tube in the supernasal quadrant, and you can end up with the nasal bleb. What I do usually, I tend to needle the bleb superiorly and redirect the Xen towards the superior area. And I also use a Palmberg suture, making sure to anchor it to the episclera and sclera. I also aspirate the bleb nasally. I feel that it relieves a little bit of tension on the Palmberg suture. This video was done basically in the minor room, and we just use an iPhone for this last video. Sometimes, if I have a dysaesthetic bleb, I'll use 2 Palmberg sutures. So here we see actually the patient before the surgery and after the Palmberg suture. And even 1 month later, he was very comfortable and didn't feel anything after that. And as I said, but this, I will do it actually more with my trap revisions. If I have a dysaesthetic bleb, I'll use 2 Palmberg sutures interspersed. And again, thank you for the very kind invitation.
Thank you very much, Younes Agoumi from Canada. Just to compare between XEN ab interno and there is now a XEN ab externo. What do you think? What is the difference between both?
Well, basically, there is a theoretical advantage for the ab externo technique, and I did 10% of my cases with the ab externo technique. Ab interno approach, you stretch the tenon, and sometimes it's hard to make sure that you go through the tenon and that you're above the tenon. With the ab externo approach, you compress the tenon against the sclera, and this allows to deploy the XEN free of tenon in the subconch space. I usually enter at 8 millimeters from the limbus and subconch, and basically enter the sclera at 2 millimeters from the limbus. So the big advantage is that in these cases, it reduces the surgical time. You can do it basically in the minor room because you don't go inside the chamber.
It makes sense, obviously. So that leads us to another mix, which is preserved flow, which is implanted ab externo. In fact, it's the same technique in XEN ab externo and preserved flow ab externo. What do you think? Between those mix?
Between the XEN and
the preserved flow, the in-focus.
The in-focus.
The in-focus.
Yeah. Unfortunately, actually, I didn't use it. It's not yet approved actually here in Quebec. But from what I heard, the results actually were very good. With the in-focus, you still have to open the conch.
Younes, can I have a question for you, please?
Of course.
Yes, I'm Ahmed Mustafa from Egypt. Now, when there is subconjunctival fibrosis around the XEN, and then you needled once, then how many times you go for needling for a XEN until you have to decide to move to another option?
So it's a very good question. I think that, it will depend on the morphology of the bleb. So if the bleb looks angry, hyperemic, with a nasty scar, these will probably benefit from open revision and removing the scars. But I tend to do 2 things. The first step, I will be basically calming the eye. I'll give steroids. Maybe I'll give something to reduce the vascularity, like an anti-VEGF. I start glaucoma drops again. In the early period, I'll try to needle them, even these cases. But if one needling didn't work in these angry blebs, typically I will tend to do an open revision after 3 months.
Okay.
Can I ask a question?
Go, Lucan.
Yes. Yes. Just sorry. I'm Dr. Omnia. Just I want to ask about the ab externo approach in all MIGS. I don't have that much experience. I did some XEN, so the only concern that we are abusing the conjunctiva, especially if this patient he will go for another surgery. So we have to be really so selective when we are choosing our patients. And when we are saying that we'll go also up external, I never tried up external. All my patients, they were up internal, but it will be more questionable why I would choose this approach, and after needling, this patient, he might need other surgery, and I just spoiled the conjunctiva. So I don't know, what do you think about this?
I think you're right, actually, and this was one reason why at the beginning I was putting them supranasally, to still have actually the superior area available for another surgery. But I have to say, right now I put them superiorly, actually, and I aim towards the supranasal quadrant, so I still have one area superiorly that is available. But I really think that, you know, if I didn't have a good answer, and if I have a very hyperemic lab with a lot of scars, I wouldn't go to a trap anyway in these cases, because I have an idea how they heal. So I would probably jump right away for a tube, and I still have the superior temporal area that is free of mica.
What makes minimally invasive glaucoma surgery is not minimally is really invasive surgery as other conventional filtering surgery. Thank you very much, Younes Agoumi, for this presentation and for your participation. Stay with us and now it's for Ashraf Armia to thank you.
So thank you, Ezzouhairi. So we have left by 4 videos. I divided them in 2. The coming 2 are dangerous, and the 2 after are refractive. So we are going to start by the 2 dangerous. I'm going to start by Dr. Lukin from Bulgaria. He's going to present a dangerous operation. He gives the title, From Routine Cataract, either it's from disaster to harmony. Now, Lucan, you can present your presentation.
Thank you. Now, is the video on the screen already?
Yes, clear.
Okay, this is a fairly routine case. It's a uniocular patient with advanced glaucoma. After trabeculectomy years ago, the other eye is glaucoma absoluto, so it's only temporal light perception. And this should be a routine surgery, but when I implanted the lens, I implanted it under water without OVD, and this was my first mistake. Then I tried to maneuver the lens, and I reached under the iris with my irrigation cannula, and this was the first mistake in my surgery. Then I tried to hydrate the wound, but something is happening. The AC is shallow, and I cannot hydrate the wound as it should be. Now probably the iris will pop up. I use my finger to see that the eye is already rock hard. I tried to push the IOL diaphragm behind to empty the Berger space, because I supposed that already there is a fluid accumulating there, but no luck. The eye is rock hard, so I realized that this is a aqueous misdirection during the surgery. I still try to relieve that pressure, but you see how the patient starting to move, so there is already a tension and pain. I realized that I need to interrupt the vicious circle, so I put one trocar, and I will do a dry vitrectomy behind the lens in order to open and to interrupt the Berger space in the anterior hyaloid, and to interrupt that vicious circle of the malignant glaucoma, if you can call that. So now I try to restore the AC, probably again mistake because I introduced more fluid in the eye. Now I will try again to close it. No luck. I will continue to do the vitrectomy, and can you see the dark shadow?
Mm-hmm.
Now something opposite happens. This is expulsive hemorrhage. Now, you see the choroidal detachment. Now, what I should do is to close all the openings of the eye. This is the day after the surgery. This is the ultrasound, the first day. Then there are ultrasounds a month later. And this is the OCT. Ultimately, after the 6 months, we ended up with 0.6 vision and everything fine. But for me, the take-home message here was really stressful. Everything can happen despite the routine and normal surgery. So this was my video.
This is so scary video, by the way, because this is a single eye patient and you are giving him the only hope, and you are facing now that he's going to ask you after the operation, I can see. So the first question in my mind, what did you tell the patient in the first day, and how you assured your patient till the 6 months?
Actually, the patient was really in a positive way about me, because she knew that I have done everything to save her eyesight. Actually, the main thing was that she had uncontrolled blood pressure, and she knew that. And it was the main reason actually for such a disaster to happen. I mean, the choroidal detachment, the hemorrhagic one, it was induced by the hypotony that I created with the vitreous cutter. But during all that maneuvers, the anesthesiologist was the main figure that was beside me, because the blood pressure was like 200 to 180. And until the anesthesiologist managed to drop the blood pressure, my efforts was more or less keeping the situation but not resolving it. After the anesthesiologist make everything fine with the blood pressure, we handled the situation. So it's tense, and you need a lot of talking with the patient, and especially with the relatives, because they are all frightened about that.
What type of anesthesia you choose in these critical cases? A general anesthesia with hypotension, or local with sedation?
No, actually, we are always using topical anesthesia with intravenous sedation. Even with in vitrectomies, we do that. So we normally use general anesthesia only for child's or keratoplasties or something like that. Still, if you don't have a good monitoring of the vital signs, and especially the blood pressure, something can come out from the blue, like this one.
Okay, and you didn't try to remove the hemorrhage from the suprachoroidal hemorrhage. You left the patient for 6 months. Why you didn't try to remove it after 1 month after clotting the blood?
Actually, I'm a vitreoretinal surgeon also, and
I know.
I have done that choroidal clot removals, and they are not always successful. And if you need to remove something which is behind the equator, the closing of this wound is more or less difficult. And there is another thing, there is a liquefaction of the blood in the choroidal space. And actually, we gave the patient only etam siwat and blood pressure control pills, and it spontaneously resolved. And this is my observation during the years, that rarely choroidal bleeding stays like organized clot. It resorbs for a month, month and a half, 2, but it resorbs.
The last question: if this operation gained with you, what you are going to do and what not going to do?
First thing that I wouldn't do is to hydro-implant the lens. This is the thing that started everything. I will use cohesive OVD, and I think it will not cause all that cascade of unfortunate events. So hydroimplantation was my mistake.
Dr. Ashraf,
Thank you so much.
Dr. Ashraf,
Yeah.
can I have a question,
Yeah.
please?
Yes. Yes.
And thank you very much for this very interesting case, actually. But the point, if you get the shallowing of the anterior chamber intraoperative, do you think fundus examination before attempting doing any kind of intervention is helpful?
I think this is really a situation which is emergency, and you need to act fast, because the aqueous misdirection can cause IOP above 60. This is advanced glaucoma eye, and this optic nerve is so fragile that 5 minutes with IOP 60 will kill it. Probably a fundus examination will reveal pale optic nerve without perfusion, and we know that when we touch the eye with finger that the IOP is high. So if you imply that the choroidal detachment I would see earlier, of course, but I know that I created it with reducing the pressure behind the lens with the vitrectomy, which I have done.
I mean, at least can you see the dark shadow of the choroid with the indirect ophthalmoscope so that you will not proceed further? Is it helpful or not? Just a message for it, because you just have said when you started to initiate hypotony, then things are getting worse. So that you think if you just stop and get the indirect and try to have a look, would it be helpful? Is it easy for you as a vitreoretinal surgeon to see the shadow of a dark choroid coming from anywhere, so to just make a rapid differential diagnosis or not?
Actually, by the time that I will get the indirect microscope, I will see that under the microscope, because if you observe the video, the red reflex became darker from one side. So this is the reflection from the choroidal bump already. So when you see changing in the red reflex, it's obvious that something is happening. Probably the first step should be to close the eye,
yes,
not to persist with vitrectomy. This is my second mistake. Yeah.
Wonderful.
Thank you, Lucan. Thank you so much. So the coming dangerous, I think, procedure is going to be presented by Dr. Yasser. He's going to, in white, milky white cataract, which is one of the problems or the difficulties that we face it, and we can have Argentina flag very easily. He's going to have his technique. It's a Phaco capsulotomy in white milky cataract. I see it's a dangerous, but Dr. Yasser is going to present it now. Present Dr. Yasser. Dr. Yasser from Morocco.
Very much.
It's nice to meet you.
Thank you very much for your invitation. So I will share my. So this is a way to avoid this is a technique to avoid the Argentinian flag in milky cataracts. So we all know this complication, and we are afraid to have it. And if there is a way to avoid it, why not? So the mechanism of the Argentinian flag is that there is there is hyperpressure in the capsular bag, and when we do the incision, there is a decrease of the pressure in the anterior chamber, and that will create a gradient of pressure between the capsular bag and the anterior chamber that will lead to extension of the capsular axis. This is a video taken from internet. It's not mine. So we all, I think, have this experience of this flag of this beautiful country, but we don't want to see it in eye. So how to avoid this complication? The technique is the Phaco capsulotomy or phacorexis. So I have a series of 53 eyes with the milky cataracts, 5 years, same surgeon. I used a peristaltic pump machine, incision 2.8. I inject the glue, then I inject the dispersive viscoelastic. I open the anterior capsular bag by the phaco tip with the pedal in the position 3. I inject the viscoelastic, then capsulorhexis by forceps, and this is a video.
To do anything. So I think when you use the Phaco probe to tear the capsule, if the Argentinian flag would occur, that will be occurred. You understand what I mean?
Yeah, I will answer to this question, because when you put a needle, the pressure of the anterior chamber is low. But when you enter in the eye with the phaco tip, you have the pressure of the machine, and it balances the pressure between the anterior chamber. You make high pressure in the anterior chamber. This is the first point. The second point is when you puncture with the phaco tip. In the same time, you break the capsule and you aspirate in the same time. It's not like the needle. So it's very fast. So in the same time, you have high pressure in the anterior chamber and you aspirate. Right. It's like so you put a brake and you aspirate in the same time with high pressure.
You can do it also by the needle. We make you puncture and we aspirate in the same time, and so we can decrease or lower the pressure in the capsular bag. It's possible.
Yes, but
is it possible?
Yes, it's possible. But when you do the incision in the eye, even if you fill with the viscoelastic, the pressure is not as high as when you put the pressure of the bottle.
Thank you very much.
Lucan, you have a question? Yes.
Yes, I have a question. The first question is, have you tried to not overfill the AC with OVD in order to keep the pressure inside the capsular bag not high? Because one of the problem is the pressure behind the lens, not above the lens. And the second question is, have you compared?
IOL power was 49 diopters. So we have managed this case in two steps. First, a cyclodiode applied in a continuous and very, very soft mode, but the IOP remained high. So a combined cataract glaucoma surgery was performed. The mitomycin is injected in subconj, as I do always. The conjunctiva was dissected as far as possible posteriorly. Never in my hand I use cauterization, only scarification to whiten and to smooth the surface of the sclera. Then I dissected the scleral flap toward the ciliary cornea, and at 2.2 millimeter paracentesis was performed. As you can see, no way to deepen the anterior chamber, no space to introduce my needle for the blue tip injection. No way to fill the anterior chamber by UVD, and the iris tended to prolapse. So I performed a pars plana vitrectomy, a limited vitrectomy, 20 gauge at 2.5 millimeter from the limbus, which allows to deepen the anterior chamber and initiate a rhexis, which it's lost behind the iris. And I completed it by scissors. The nucleus is removed through this small, very small pupil, and then the cortex is cleaned. After that, I tried to make syneculosis without gonio lens. The cornea was not very clear. Some bleeding, but the situation is controlled. And I injected 2 IOLs in a piggyback manner. I'm not happy. We don't have in Morocco a customized IOL such as Nancy showed in his video. After that, I performed a trabeculectomy with a puncture and an iridectomy. The scleral flap is closed by 2 separate sutures with nylon 10-0. And always I add a 3rd suture, an adjustable one with 6 loops. Tighten very, very strongly and laid on the surface of the sclera really very, very, very strongly. And at the end, I adjust the tightening by the pressure created by the balanced salt serum injected into the anterior chamber. Finally, I sutured the conjunctiva with 4 interrupted sutures, buried sutures also. And at the end of surgery, I had checked that the anterior chamber is deep and maintained stable, 2 that there was no leaking, and 3 the bleb, as you can see, is formed, is high, and is diffuse. Here I show you the results after 1 month. The left eye was lost. The intraocular pressure 13 millimeter mercury. The best corrected visual acuity 20/63 with a clear cornea, and she kept a long-standing retinal edema, which need a management by some EVT. Thank you.
Yeah, thank you, Ezzouhairi. Very nice surgery. But I want to. I have 2 questions from the cataract point of view.
Yes.
Why you didn't use an iris hooks to make your rhexis easy a little bit?
I use hooks, iris hooks, in some cases when the pupil is really very, very tight. I'm very easy with this kind of pupil, as I am glaucoma surgeon, and I am a lot of patients with exfoliations and with not a lot not dilated pupil. So I know how to manage these cases, and I can initiate and practice my rhexis even behind the iris, even hidden by the iris. I can manage this type of challenging cataract. But if the pupil is very, very tight, less than 3 millimeters, of course, I use hooks, iris hooks. Your second question, Ashraf?
No, Yunus, have a question, yes.
Yes.
Yeah. Thank you. It was very interesting. Thank you, Dr. Ezzouhairi. And as our beloved Dr. Bron said, we all come with our background, actually, and there is no better person for a trap than you. But I really, I just had a couple of comments, actually, for this case. The first thing, actually, for nanophthalmic eyes, as you said, sometimes you don't have even space to enter your instruments into the eye. So I always do a vitrectomy, a small core vitrectomy before that. And it also allows me to do iridozonulohyaloidotomy after that to avoid any malignant glaucoma, because I saw a couple of cases of these cases. You do the surgery, you're very happy, and still after that, you need to you see a malignant glaucoma coming. So this was my first comment. Second comment was about the IOL. I mean, yeah, you don't have access to the IOL, and she was very lucky to have you actually over there. But I agree, I tend to use more one IOL inside the bag, like the Extreme D or the Aspira. And the reason is that I want to avoid any UGH or any secondary pigment dispersion in these cases. The third comment is about basically glaucoma management. As we know, the main component here is probably just the lens by itself. And sometimes we're surprised. We just remove the cataract and the pressure goes down. So in these cases, I try to avoid trap or tube, at least in the first surgery. I try to do either a Phaco ECP, endocyclophotocoagulation, or Phaco goniosynectialysis as a first surgery, and then actually I leave it for a tube, actually.
Of anti-VEGF with good results.
Why anti-VEGF but not steroids?
In my opinion, I avoid steroids in glaucoma patients. It's my principle with these eyes. I try to use the anti-VEGF as anti-inflammatory action.
Yes, but here the problem is actually the open ciliary body, which induces a chronic inflammation, and that leads to chronic CME.
But excuse me. Yes, I forgot just an information. In my hands, when I practice, when I perform cyclodiode, I performed in a soft mode, which means I use very low energies, but the parameters is really different in my hands. The power is only 1.2 or less watt, 1.2 watt or less, never more. I never tend to obtain pops. That is the first thing. I treat 360 degrees sparring 3 and 9 o'clock. And I treat the ciliary body in 3 rows. In this case, with small eyes, I treated it only in 2 rows. But I use also always transillumination to treat more accurately the ciliary body. This one. And another information, at the end of these procedures, I inject in subtenon always the triamcinolone.
We can move to the next presenter.
Thank you. So for the next speaker is Ahmed Mustafa Abdelrahman from Egypt. He will talk about glaucoma secondary to elevated episcleral venous pressure. Please share your screen.
Thank you very much, Dr. Ezzouhairi, for the kind invitation. I'm so pleased to be with a distinguished group of surgeons. Okay. Yes. Now I have nothing to disclose about this situation. Now this is my patient, the facial appearance of her in general. Now what's the situation? She is a 40-year-old lady. She's having a congenital heart disease, and she had right-sided heart failure, severe pulmonary hypertension and lung fibrosis. The pressure in the right eye is 30 and the left eye is 42. She's under all full treatments for glaucoma. She had a history of argon laser treatment to the retina. She had rubiosis iridis and blood in the Schlemm's canal in both eyes. The right eye is hopeful with vision of 0.2. The left eye is no PL. The right disc shows 0.7 cupping. The left eye is not seen because of vitreous hemorrhage. So this is the situation. Now let us focus more on the patient. She is severely cyanotic because of the severe pulmonary hypertension and lung fibrosis she has. She has severe clubbing of her fingers so that she comes to the clinic with her oxygen on her back. And now this is the left eye, which is with the no PL, and you can see the episcleral vessels are very engorged, and some vessels on the iris. And then this is the more hopeful eye, and you can see also the episcleral vessels are very, very dilated, and the pressure in these eyes is 32 under full treatment and some robiotic activity on the iris. So it is just what's happening now is that the intraocular pressure is the calculation of the rate of the aqueous formation divided by the facility of the outflow plus the episcleral venous pressure. And now my situation is that this patient is having severe elevation of the episcleral venous pressure that resulted in secondary open-angle glaucoma and the blood in the Schlemm's canal. But that was reflected on the retina as well by having ocular ischemia and new vessels. And that's why she received laser treatment to the retina. So it started by massive elevation of the episcleral venous pressure with subsequent ocular ischemia as well. Now, regarding the possible interventions, we need to manage her glaucoma because now she is one-eyed. Shall we go for trap? Shall we go for valves? Shall we go for cycloablation? Any other option? Please, I want to hear from you before I proceed, if possible. So any comments regarding what should be the best option that we go through? Trap, valve, cycloablation, others? Okay, and then
Dr. Ahmed, for me, I'm going to have an intravitreal injection of anti-VEGF first.
Yes, good. Without doing anything else, yes? Yes, good. And then what other? So we have others, intravitreal injection, yes. Any other option for this?
Valve procedure will be a more option in this.
Yes, this is also a good option as well. So the point is that then I will proceed for the interest of the time. And then some considerations in patients with episcleral venous pressure when it is elevated, that medications and interventions that reduce the aqueous formation might be more effective than drugs that increase the outflow, especially the trabecular outflow, because the trabecular outflow is hindered by the elevated episcleral venous pressure. However, prostaglandins are sometimes effective because they work on the uveoscleral outflow. There is no place for laser trabeculoplasty, though it's an open-angle glaucoma. And then filtering surgery, as we know, might be complicated by ciliocoroidal effusion or hemorrhage because of the high pressure. And then manipulating the subconjunctival space is not easy when there are lots of blood vessels of venous dilatations in the episclera. It's not easy to open the conjunctiva or to do diathermy or to prepare the eye for any kind of filtering surgery or even valves. For that reason, I opt to go for diode cyclophotocoagulation and inject at the same time intravitreal anti-VEGFs. And then I decided to do that for both eyes, for the right eye as a management of the intraocular pressure and saving this eye, and for the left eye because the pressure is 42 and the patient is in severe agony. The treatment parameters are not those. I use 1,500 milliwatt for 3 seconds and around 30 applications. And what happened is that after that was the treatment. So it is a regular treatment for transscleral diode, but it's a bit like more shots, like 30 shots. And then what happened in that the immediate post-operative, I had a pressure of 20 millimeter in both eyes. That was a bit relaxing. And then 3 months after the operation, the right eye intraocular pressure is 16 millimeter on a combination of beta blocker and carbonic anhydrase inhibitors. And the visual acuity is the same, is 0.2. The left eye, the pressure dropped from 42 to 28, and the patient is now having no pain, and I achieved my targets. So at that time, I felt quite happy. That was 3 months after the operations. And then when it comes to managing patients with elevation of the episcleral venous pressure, we need to think of treating the cause, and we will see a list of causes. And then for the glaucoma, we have to make one of two options, either options to decrease the aqueous production, whether medically or surgically, or the other way is to increase the aqueous outflow. For the measures to increase the aqueous outflow, especially surgically, they are technically very difficult. The outcomes are poor with some complications, especially intraoperative, so that I opt for laser transscleral diode to help the patient having better intraocular pressure in the light of the recent publications that diode cycloablation or cyclomodulation, let us call it in a gentler way, is useful in seeing eyes. Now let us go for the Goldman equation, where the intraocular pressure is the rate of the aqueous formation divided by the facility of the outflow plus the episcleral venous pressure. Now in this patient, we work to decrease the aqueous formation that will be reflected on reduction of the intraocular pressure. And now, if you can treat the cause as well by decreasing the episcleral venous pressure, you will get a more reduction of the intraocular pressure. This is not the end of the story. Now, the patient presented 1 week ago, like 2 months after surgery. The intraocular pressure was 19 under the same topical medication, which is a combination of beta blocker and carbonic anhydrase inhibitors. And now she's complaining of some blurring of vision. In the first place, I was so happy to see the patient's 10 months because she didn't come for follow-up during that period. And what happened? Her lung condition and her heart condition slightly improved so that she can come to the clinic without her oxygen. That was really interesting. And that what happened at that time, the patient had her cataract aggravated. And then I had a discussion with the patient that I needed to go for cataract surgery, and I don't see the fundus very well. Just in case, I will inject more anti-VEGFs because I don't see the retina very well. And then the patient accepted that intervention. Interestingly, surgery was uneventful. I was afraid from the pupillary dilatation from the previously treated eye with diodes for the condition of the retina, but everything went fine. And what happened is that out of my expectations, after cataract surgery and the injection of anti-VEGF, her best corrected intraocular, her best corrected vision is 0.6. This is to my astonishment. And her intraocular pressure is now 12, so that she's in a much better situation right now. Now, this is another case where the episcleral venous pressure is elevated in Sturge-Weber syndrome. And we know very well that Sturge-Weber syndrome can elevate the episcleral venous pressure and can cause glaucoma, especially in adolescents. Now, she was a one-eyed patient as well. The other eye was lost through treating the retina with radiotherapy for the choroidal angioma. And this is the situation of this eye. We can see a kind of cupping, and her pressure was 35 on full treatment, some vascular changes on the optic nerve as well. Now, this appearance doesn't give you the clue that the patient is having choroidal angioma or not. So we ask it for ultrasound, which shows diffuse thickening of the choroid. So the patient is having diffuse choroidal angioma as well. And now from that point of view, I thought I am not going to open an eye with elevation of the episcleral venous pressure and a choroidal angioma as well. So why not to go for transscleral diode? And that was the situation. The transscleral diode, I use low settings, and I like to mark the cornea because this helps me in delineation of the horizontal meridia to avoid during treatment and to have a decent distribution of the laser shots, which at the time being, I use 24 shots with the same parameters. So in conclusion, diode cycloablation helped in intraocular pressure control in cases with elevated episcleral venous pressure. It avoided the possible side effects of the other IOP lowering procedures beside the technical difficulties. I'm not quite sure that opening the subconjunctival space with the angiomas in the episcleral tissue it's going to be an easy thing to do. Now, for the causes of the elevated episcleral venous pressure, there are a lot of causes. Could be venous obstruction, and here we presented a patient with congestive heart failure and marked elevation of the venous pressure and episcleral venous pressure, and a case of Sturge-Weber syndrome, and both patients are treated nicely with transscleral diode cyclophotocoagulation, and I am so happy with the results of those patients so far. And those are my references, and be safe. And I would like to thank you all very much. And if you have any concern or anything, this is my email for future communications. Thank you very much.
Thank you very much, Ahmed Mustafa, for this nice presentation, interesting presentation. I have one question about cyclodiode. I said that the transillumination, I use always transillumination because for me, the location of the ciliary body varies from one eye to another eye for one person to another person, and the distribution is not circular, is elliptical in on the eye, and it depends also on the length. The actual length of the eye, it depends on many factors. So when we applied cyclophotocoagulation without transillumination at 2 millimeters or 2.5 millimeters, 1.5 millimeters, it depends also there is different protocols, we don't focus accurately on the ciliary body, and we can burn the anterior segment with a lot of inflammation, and we can miss the ciliary body, and so the results become unpredictable. For me, it's very, very important. It's capital is to use transillumination to know when where I do put my probe, my tip on the eye, on the eyeball. What?
Yeah, Dr. Ezzouhairi, then you are forcing me to expose one of my secrets in treatments here, because why I'm using the corneal marker. The corneal marker is a 16 blade marker, and then it will leave 16 marks on the cornea. And then by that, I leave the 2 horizontal marks on either side, and then I'm left with 6 marks inferior and then 6 marks superior. Then when I treat, for the reason that you have nicely mentioned, that I don't put the burns on the same level, but rather it comes to every arm of those 6, and I apply 2 marks, which are bit 1 mark, and then 1 millimeter behind, I apply the second mark, so that now we are having a total of 12 marks inferior and 12 marks superior, so that in case the ciliary body anatomy is variable. And for that, I'm so happy for that situation, and I sent that technique to the American Academy of Ophthalmology, and hopefully to be presented this year. But I totally agree with you. If you have trans-illumination, that will be very helpful, and that's why the machines now of the machines, and they are producing probes which are having trans-illumination at the same time. Yeah, so you're absolutely right.
About the burns, or in fact, you use 2 rows of treatments.
Yes, yes. The point is that you know that I'm not quite sure when you treat the entire ciliary body is something very useful. That's why I think the treatment shouldn't be mentioned as cycloablation. It's a very frightening terminology.
Yes,
I call it
of course, I agree.
Because you have applied it to a seeing eye, nanophthalmic eye, and I'm applying a lot to seeing eyes, whatever the level of the visual acuity, so that I think we shouldn't treat the entire 360, so that I think when I apply in a kind of 2 rows, I'm leaving good healthy parts of the ciliary body, and that's why I'm so fortunate that I'm not having cases of hypotony or atrophy.
Did you have compared continuous cyclodiode with macropulse, and what is your opinion about macropulse compared to continuous waves?
Yes, and actually the micropulse is an emerging technology as well, and I think the parameters are going to be further rarefied for a much better outcome, because I know some of our colleagues are disappointed from the results of the micropulse. But the point is that with the micropulse, there are certain precautions with its use. Anyhow, to get to your question, we have compared the micropulse to the continuous wave diode in the children with refractory congenital glaucoma.
Yes.
And it was very, very interesting that we got a bit higher even success rate, though not statistically significant, compared to the continuous wave.
Yes, I agree.
That micropulse is an emerging technology with lots of modifications nowadays, and that's why the micropulse treats the ciliary body elegantly, and so that I'm saying that we do not have like a cycloablation or cyclodestruction, a very very frightening technology, of course.
Yes, so of course we treat the ciliary body, but also we improve the outflow through canal Schlemm's canal, and also the suprachoroidal pathway with the same technique. So we improve the outflow, and we decrease the secretion and in the eye.
But to help the outflow to improve at the same time, so far you have to use a power of 150 joules, which is, I think it's a better matter of debate nowadays because of its effect on the limbal stem cells. So that's why lots of, understanding of the technology is happening nowadays.
in my opinion, it depends on the location of the burns.
We should move
yes, just a last comment. In my practice, I treated 2 patients with Sturge-Weber syndrome without results with cyclodiode, unfortunately without any results.
But it's a repeatable technology. That's the point.
Yes. Yes.
That you can repeat.
Yes. Yes.
And you can add medications, Dr. Ezzouhairi. It's not an absolute success, so that most of those patients are still on topical medication,
exactly.
but the pressure is within the target.
Exactly. So we move to the next presentation. So it's for you, Ashraf Armia.
Yes. Yes. I'm going to have the 2 refractive part of the session of the cataract. The first one will be by Dr. Anas, one of the most experienced surgeon in this field from Syria and from UK. So he's going to present a very, very questionable topic, which is a premium IOL in post-keratoplasty. Please, Dr. Anas.
Can you hear me?
Yes, we can hear you.
I can see my screen, yes?
Not yet.
Oh. How about now?
Not yet, Dr. Anas.
Good evening to you all. I'd like to thank the organizers for the invitation to be among this distinguished faculty and talk to you today about cataract surgery and premium IOLs in post-keratoplasty. It's really about the factors influencing the decisions of cataract surgery and premium IOLs in post-keratoplasty corneas, which are different than the one in virgin cornea. We had this referred at our center, 56 years old female, with a complaint of gradual visual loss and a history of penetrating keratoplasty post-herpetic eye disease. Examination showed cataract with clear corneal graft. Let's go through the factors to determine what to do with this patient and with post-keratoplasty cataract patients in general. If you plan to do cataract and IOL in post-keratoplasty, then you need to look at the endothelial cell density, a risk of disease recurrence, and graft survival. Because for your information, endothelial cell loss is 50% in PK at 5 years and 4 to 22% in DLK at 5 years, depending on the technique. Keratoconic eyes in post-keratoplasty show continuous astigmatic changes and recurrence at the 3rd decade in 11% of the cases. Corneal graft host junction heals by 1 year post-PK. However, this may vary depending on patient's age, general health status, and the use of immunosuppressive agents. How do we reach refractive stability? It is by removing sutures at 1 year post-PK and confirming stable refraction on 3 successive visits with 2 to 3 months in between. A quick word about post-keratoplasty, cataract, and astigmatism. In post-keratoplasty, 1 in 4 patients has cataract. In post-keratoplasty, the astigmatism average is between 4 to 6 diopters. In post-cataract surgery with virgin corneas, 1 in 4 has astigmatism 1.25 diopters or more. If you add all these together, then you conclude that dealing with astigmatism is as important as dealing with cataract and post-keratoplasty. Can we use toric IOLs in post-keratoplasty? Toric IOLs eliminate regular cornea astigmatism. However, it is contraindicated in eyes with plans for RGP contact lenses and regrafting, and in eyes with potential capsular instability and moderate to high irregular astigmatism. How do we calculate the biometry? How do we obtain the lens power in post-keratoplasty? We can obtain the K value using the holiday report EKR 65 from the Pentacam machine, and the axial length from the optical biometer. We enter all the values to the Barrett Universal 2 formula. And remember, if you're planning for indectable, you should consider a myopic shift, because there's the hyperopic shift in both DZEC and DMAC. Now, is marking the axis different in post-keratoplasty? No, it's just the same like in any other eye. And the source of errors are the same. However, we can always make our life easier by using the new devices integrated into the surgical microscopes. Any relation between IOL material and rotation? Yes, indeed. The hydrophobic acrylic IOL tend to rotate the least. The hydrophilic rotates more, the PMMA rotates even more, and the silicone much further. Remember that the higher the cylinder power, the higher the rotation. We choose spheric or aspheric IOL depending on the amount of total spherical aberration. And if you're planning for anterior keratoplasty and air injection in the anterior chamber, we mustn't use hydrophilic acrylic IOL because it interacts with the air bubble and gets opacified. Phaco incision should be posterior to avoid the graft-host junction and to produce as minimal astigmatism as possible. The size should be 2.2 for the same reason. We should protect the endothelium by means of injecting dispersive OPD as part of the soft shell technique described by Arkinov, who used dispersive and cohesive OPD. During surgery, we should lower the infusion bottle, use mechanical forces, high vacuum, and perform phaco as far as safely possible from the endothelium. If we're not sure that the capsule or the zonule are intact, then we should remove the capsule and use scleral fixated IOL. Do we use sutures at the end? Yes, for the main incision. Even for the side port, if it leaks, and we remove the suture at 1 month post-op. The management for misalignment in post-keratoplasty is the same as in any other eye. Is there a role for presbyopia correcting IOLs in post-keratoplasty? It is contraindicated in PK and DLK because PK and DLK grafts induce significant anterior and posterior high order aberration. And it is contraindicated in DZEC as well because DZEC grafts induce significant high order aberration and reduce contrast sensitivity. DMAC grafts induce less posterior high order aberration, and there are ongoing studies on uneventful DMAC with presbyopia correcting IOLs. What about the follow-up? After the cataract, we should increase the steroid frequency to reduce the risk of rejection and do close follow-up. We used to do triple procedure for patients with cataract and corneal pathology. We do the cataract, IOL, and the corneal transplantation at the same time. But now we do the keratoplasty, and then we remove the sutures, achieve refractive stability, and then we do the biometry. We think that it is more accurate prediction of IOL power this way. This is my algorithm for the IOLs in post-keratoplasty. Well, thank you very much.
Thank you so much, Anas. It's a very comprehensive presentation, but I have two questions, really. If you are doing cataract post-keratoplasty,
yes.
you definitely are going to face by refractive surprise. What's your preferable way to do the post-refractive? Either you are going to do LASIK or you are going to do surface ablation.
This is a very important question. Well, First, we need to use the holiday report, EK R65. This will minimize the refractive surprises. I found in practice that we can avoid doing our procedures afterwards. We can use glasses, you know. But if I have to do anything afterwards, the way is open for add-on IOLs. I'm a bit fan for IOLs. I would stay away from manipulating the graft.
Okay, Lucan, you have a question?
Yes, I have a comment, more or less. I wouldn't use any diffractive lens in post-keratoplasty eyes because the Fresnel optics can induce a lot of unwanted phenomena. I didn't hear you say something about the pinhole lens, the IC8, which I regularly use, especially in post-RK cases. We have a lot of post-RK cases now, and I don't think there is a room even for toric lenses or any other optical correction in corneas which are highly irregular.
Yes, I can't agree more. Toric IOLs are contraindicated in moderate to high irregular astigmatism. But it would be very interesting to see the IC8 role later on.
It works. It works.
Thank you very much.
Thank you, Anna, so much. So I'm going to present, I wanted to make my presentation the last, and it's also refractive. It's little bit IC8 like what Lucan said. It's the same way. So I'm going to share my presentation. I call the presentation, it's a pinpoint pupil. When there is a with a toric there is a refractive error, and there is a extremely high astigmatism and intractable to do refractive surgery of the cornea. My technique, I give the credit really to Ammar and Priya Narang from India, because they make me combine their technique with the toric IOL in this case. So I am going to present this patient. This is a Syrian patient, 36, came to me for a refractive correction for the right eye. On examination of the right eye, I found that she had an iris glaucoma also around 3 o'clock hours with normal posterior segment. Her cycloplegic refraction was +7 sphere, -5 cylinder, with the best corrected visual acuity was 0.4 with +6 sphere, -4.5 cylinder. Her left eye was perfectly with non-significant error at all. She's perfect, and she's asking me for a refractive surgery. So I asked for a pentagram as usual for femto laser correction. This her pentacam. It's the astigmatism is regular. I don't have any problem. The thickness is okay, but I have some elevation in the posterior segment, maybe from the high astigmatism, but I don't have any problems. But this is not the usual pentacam that I go for LASIK for and be safe. So, and also when I put the equation between the high error she has and the femtolasic, I choose to do a combined procedure. That I put a toric IOL in this patient. Also, I'm going to correct the glaucoma to a pinpoint pupil, so I can have both benefits of the two procedures. So this is the operation. As you see, there is a glaucoma here. So in these cases, you should have a good rexus. This is very important. CTR is a mandatory in iris glaucoma patients when you put an toric IOL to decrease as much as you can the rotation of the IOL. I have some problem when I put the CTR. It was not in the bag, so I could manage it. Not easy, but I could manage to put it inside the bag. After many time, I succeeded, so I put it inside the bag. But this site, I don't like the site of the CTR like this. I should move it because this is the site of the weakness of the sinews. So you should move to make it the CTR like this. I mark my astigmatism, the steepest meridian, and I put the toric IOL. Then with a single pass 4 through pupilloplasty, which is my technique now, thanks to Ammar also, I close the glaucoma by 3 sutures. I make a rounded pupil for the patient, and this is post-operatively. The best corrected was before the operation it was 0.4 with the maximum correction, but after the pinhole pupilloplasty, I reached 0.8 with the refraction plus 0.25 sphere and 0.5 cylinder. What is the idea of this technique? Performing a pinhole pupilloplasty helps filter the stray light from the periphery. It also blocks distorted and unfocused light rays, reducing the aberration, which is a very important, and enhancing the visual acuity and its image quality. What was known that pinhole devices mitigate the impact of the corneal aberration. Pinhole visual acuity is an indicator for visual potential of the eye, and also the same procedure for the corneal inlays and the contact lens. So the trick in this, when you do a pupilloplasty and you decreasing the size, the most important is use your Purkinje image helps to locate and create the center of the pupil, because you are going to decrease it in size, and the Purkinje image is your help to locate the small center of the pupil. Thank you so much. Thank you. So I can give the talk to CD again.
Very nice presentation, and I will ask you if you can share with me your technique to tie your pupil. Very nice.
Yes, I learned it really. I learned it from Ammar and Ashfin since more than 4 years. The single pass 4 through pupilloplasty changed the iris repair for me, definitely, by all means. It's very fast, it's elegant technique, and you do the knot in just one step. Very easy, and use it with the 10 or even the 9 operating sutures.
I tried many techniques, but it's not usually it's not easy. It's really difficult to manage this kind of sutures inside the anterior chamber. I'm really interested by your video, and thank you. So we move to the next speaker, my friend, my brother from Algeria, Jalal Aberkane. He's going to talk about how should I manage neovascular glaucoma. Do you hear me, Jalal?
Yeah, I hear you. Do you hear me?
Yes.
Yes. Firstly, I'm going to share the. Okay, that's it. Okay. First, I want to thank the organizers for this very kind invitation, and you, dear brother Sidi Mohammed, for your very kind words for me. Thank you very much. Very harmful. I would like to talk with you about neovascular glaucoma, and to share with you 3 cases, clinical cases, and to see how to manage these cases. Neovascular glaucoma quickly is a serious complication of several retinal disorders. It is potentially blinding, secondary glaucoma, and therapeutically challenging and with a poor prognosis. The mechanism is this neovascular glaucoma come after secondary to hypoxic retina, which produce angiogenic factors that stimulate new vessel proliferation in the anterior segment. And the most common causes of NVG are central retinal vein occlusion, diabetes, central retinal artery occlusion, and ocular ischemic syndrome. About central retinal vein occlusion, the incidence of NVG is correlated with the extent of retinal capillary non-perfusion. And we must remember the 100-day glaucoma. It is the most reliable predictor is initial visual acuity. Diabetic retinopathy, almost 21% of all diabetics with proliferative retinopathy will develop neovascular glaucoma, and almost 80% after pars plana vitrectomy. Central retinal artery occlusion is an uncommon cause because the severe ischemic damage the inner retina and reduce the reduced production of vasoproliferated factors. And we must remember that if glaucoma occurs, it will be in a quick fashion. Rapidly, the stages of neovascular glaucoma. Stage 1, it is early new vessels on iris or neovascularization of the angle with open angle and normal intraocular pressure. Stage 2, we have clinically evident neovascular on the iris and on the angle with open angle and intraocular pressure between 20 and 30 millimeters of mercury. And the stage 3 is a prominent neovascularization in iris and angle with angle closure and extropion uvea and IOP over 30 millimeters. Let us see some clinical cases. The first case was a 9-year-old male with blurring of vision in his right eye for the past 3 days. In his history, he has arrhythmia, angioplasty, endarterectomy, and hypertension. The best clinical visual acuity of his eye was hand motion. The media, looking to his great age, was not clear. He has a cataract at grade 3 to 4. In the right eye fundus, despite not very clear media, we can see a central artery occlusion. And the IOP in the beginning was 18-16. We tried an incomplete PRP, pan-retinal photocoagulation, because of the media that was not clear. For several reasons, we lost him to follow-up. And he came back 25 days again after with pain and redness of the eye. He has neovessels on iris and angle and an intraocular pressure that was very high, 54 millimeters. We began treatment, and the initial treatment was medication to try to control the IOP with medication, with the mannitol intravenous and oral carbonic anhydrase inhibitors, topical beta blockers and carbonic anhydrase inhibitors, topical steroids to relieve the eye pain, and after 2 weeks, we have injected anti-VEGF. We saw a partial regression of his new vessels on the iris and on the angle, and the IOP was brought down to 25 millimeters. And after, when we observed that there was still a partial neovascularization, we opted, in the case of his great age, for a cryotherapy, and after 1 week, the IOP brought down to 19 millimeters, and the patient is now comfortable. The second case is a 63-year-old woman with hypertension, angioplasty, with central retinal vein occlusion with new vessel glaucoma on the left eye. The IOP was high to 42 millimeters of mercury. She had a corneal edema new vessels in the iris, open angle with new vessels in the angle at almost 270 degrees. The best corrected visual acuity of her left eye was finger counting. We proposed this treatment, systemic hypotensive agent, a full regime of topical anti-glaucoma drugs, an early panretinal photocoagulation after clearing of the cornea, and we saw a regression of the new vessel on the iris over 2 weeks. On the angle, we saw a peripheral anterior synesthesia at 2 clock hours. At 8 weeks, the intraocular pressure was brought down between 16 and 21 millimeter of mercury. At 3 months follow-up, the IOP rose again at 30 millimeter. There was no active new vessels in the angle, and so we chosen to do a trabeculectomy with mitomycin. At 6 months follow-up, there is still an eventful glaucomas, and the eye is stabilized. The third case is a 63-year-old male with a sudden blurring of vision of the left eye with new vessel glaucoma with proliferative detachment, the proliferative diabetic retinopathy and vitreous hemorrhage. We began by medical treatment, anti-VEGF, panretinal photocoagulation in visible area. After 1 week, we saw partial regression of new vessels. The IOP was 36 millimeters. We choose to do a pars-plana vitrectomy with endolaser combined with tube surgery, and the IOP was between 15 and 20 millimeters of mercury at 2 months follow-up. The goals of treatment is the reduction of the IOP and the removal of the ischemic focus that produces vascular endothelial growth factor, VEGF. How can we reduce the IOP? By aqueous suppressants, oral acetazolamide or IV intravenous mannitol may be needed if acute and very high pressures in presentation. If the intraocular pressure is uncontrolled medically, glaucoma drainage device can be proposed. We propose transscleral diode cyclophotocoagulation for poor visual potential, and trabeculectomy with antimetabolite is a good option in surgery when IOP is persistently elevated despite regression of anterior segment neovascularization. If there is still new vessels in the angle, trabeculectomy will not be the good option, and glaucoma drainage device will be better. Removing of the ischemic focus that is producing the VEGF, we have to treat the underlying condition when it is possible to do panretinal photocoagulation if media is clear, and if media is not clear, we can choose transscleral diode laser retinopexy or cryotherapy or pars-plana vitrectomy with or without lancectomy and endolaser. Anti-VEGF therapy can do a rapid regression of new vessels in the iris after intravitreal and intracameral anti-VEGF. It reduces the complications, which are inflammation, intraoperative bleeding, and it can improve. It improves outcome of glaucoma surgery. This is my references, and I want to thank you again for your kind invitation. It's a great honor for me. Thank you
very much for this comprehensive presentation of General Aberkane. Some comments maybe from Ahmed Mustafa. Do you have some comment?
Thank you very much, Dr. Jalal. This is really a very nice, comprehensive treatment. And I like very much when you have said at the conclusion that removing the focus of ischemia. That was really very interesting and very touching. Thank you very much. A very nice.
Thank you.
Thank you very much.
Another comment is about gonioscopy. Gonioscopy is really one of the keys to have a good management of neovascular glaucoma and in general in new vessels in the angle and the iris, and all patients with these concerns of the diabetics and so on need to be checked regularly by gonioscopy and to grade their new vessels, their neovascular rubeosis, and to manage depending on clear cornea or not, on the grade, and if there is vitreous hemorrhage or not. This is what this is my comment on this nice presentation. Thank you very much, Jalal Aberkane. We move to the next, the last and not the least, Omnia from Abu Dhabi. It's your talk is about surgical management of longstanding ocular hypotony after glaucoma surgery.
Yes, I have to find now the yeah. My case, actually, I will share with you a case. Maybe I discussed it before with Professor Ahmed Mustafa a long time ago, but I love to share this case. It's about a young man with 28 years old. He presented to our clinic complaining of severe decrease of vision post-glaucoma surgery. So this young man, he had severe ocular hypotony for 8 months post-express shunt glaucoma surgery. And he came actually for second opinion as his vision before surgery was 6/6, but the vision post-surgery and for 8 months was 6/60. Ocular pressure was 2 when he came to the clinic, and with very huge bleb from 3 to 9, diffuse and high bleb, and macular folds with retina folds. This patient, he underwent also 2 revision by his surgeon to resuture the flap. And when he came, of course, for a long time, he had this poor vision. I was really hesitant to go for any surgery, so I chose to do for him conjunctival bleb compression. I did it twice. First time, I used Vicryl 80, and pressure next day was 23. I was so happy, but I lost so fast the sutures. Like 4 days after that, I lose the sutures. I took him one more time to the operating theater, and this time I used nylon, 10-0 nylon, and the same thing happened. I lose the sutures. Then I said, okay, I'll go for autolog blood injection. I inject him 4 times, this patient, in the blood. And actually, it wasn't useful at all. This patient, he used to have, actually, the increase of the pressure was really temporary. Here, I decided to take the patient to the operating theater and to open and see. My concern that this patient has been operated twice for resuturing his lab or his flap, and I had the concern that maybe I will not find healthy tissue and maybe I will not be able to close it. So actually, this is what I found: melting sclera, and the express was totally exposed, and the flap was just stuck to the tenon and the conjunctiva. When I go to for this surgery, I programmed that I'll do the surgery on the same day when my colleague, who is a corneal surgeon, had corneal graft. I took this part of the cornea and sclera to close this melting area. In my actually, my perspective, I was planning to have scleral, to take on the sclera and to put this patch of flap. I cut it. I tried to suture it, and it wasn't easy, by the way, because it formed like fold with me. So I cut again. I tried to trim it, and I end up by that it's really even melted posteriorly, and I cannot close it properly. At this point, I found myself, because my objective when I was operating, my objective was to maintain adequate filtration. I don't want to have this patient with 40 IOP next day. So with this small scleral flap, it wasn't really useful. So I took the cornea with the sclera at this time. So I take the sclerocorneal patch, big one. I removed this one, and while I was operating, I had also this question: I remove the express or not? Of course, very early I said no, I will not remove it, because still I want my objective to maintain adequate filtration. So I have to close it, but I have to maintain adequate filtration. So here I put my flap, the corneal scleral flap. I suture it with nylon 10-0. And I went to the back. I put my suture in the middle, so at least I will not have folds on this flap. I tried to make it smooth as much as I can. And here I suture it. Just to mention that this patient, he had already mitomycin for the first surgery. And here I checked also the filtration. Of course, I had viscoelastic to maintain my anterior chamber all the time. And here I washed the viscoelastic and I checked the filtration. I was planning always that the filtration will be posteriorly, so I have to be tight anteriorly. And good chance for this patient that, of course, because he had long-standing huge bleb. So so here I'm closing because it was there is more filtration on the laterally, and as the conjunctiva was really expanded for a long time, so hopefully that I had really relaxed and a lot of conjunctiva. Because at this point, when I'm seeing the cornea and the sclera just above the melted sclera, it was so huge. So you say, okay, how can I close the conjunctiva? But of course, because of really expansion of the conjunctiva, this step was easy to close it. Yeah, this patient, next day he had 16, his pressure was 16. 2 months after, his vision was 6/6 partial, retina fold, the macular fold totally resolved, and the IOP 12. And this patient being operated 4 years ago, still I'm seeing him twice per year. No medication, his pressure always 12. He has, of course, some mild nuclear cataract since the hypotony event, but his vision is 6/9 or 6/6 partial. He's happy, and just I learned actually from this case many things. The most important thing that we have to think always about the underlying sclera. I was thinking first about the conjunctiva, to close it, to block, but when it's not working, so we have to think that maybe the underlying sclera is unhealthy. And in this case, to open such a patient, we have to take really a precaution and at least to have flap or patch just beside us for such cases. Yeah, this is my small experience about this case. Thank you.
Very, very, very interesting, impressive surgery and case. Congratulations for your surgery and for sharing with us. Really, very, very interesting. So I have a question about hypotony. How to define in your case? Of course, there is a hypotony, but in general, how to define hypotony? It's linked only on intraocular pressure, or there are other concerns to take into account?
Yeah, I think that the IOP is this 6 millimercury or less. This is a hypotony already. Yes. And of course, I have to take in my consideration the corneal thickness if I'm talking about, because when I'm talking about patient post-op, it's not like I'm talking about patient with low ocular pressure, because it might be a little bit manipulated by the corneal thickness. But anyway, hypotony, to say hypotony, I think 6 millimercury of IOP or less, this is already a hypotony. And if it's already combined by some signs like the folds, macular folds, or retinal folds, so yeah.
I have a question, Dr. Omnia. I have a question.
Yes.
If this your case, for how long you're going to stay for hypotony in this patient?
Yes.
You are going to leave him for how long? Because when the express valve started by Alcon, usually the recommendation with the company is that you close the flap as tight as you can, and you don't be afraid of them, because I used with mitomycin with the closing of the. But for how long? Because you have a severe hypotony, macular edema, and after you put the graft, for how long you recover the vision for this patient?
Yeah, for my patient, he recovered after 2 months of the flap of the graft. But if this patient is my patient since the beginning, but already he has been operated, by the way, by one of the intelligent and famous surgeon, and he tried twice to close it. I had only his report, surgical report, but I saw that he opened and he tried to tie the flap twice. And then we don't know what happened. Maybe sometime, we get bored from the patients, or the patient they disappear and they go to different doctors and they don't know what to do more. And they refuse to go back to their main surgeon. I don't know, maybe this is what happened, but I'm sure that he has been operated by really very expert hands. Anyway, if this patient, he is my patient since the beginning, maybe after 3 months, I'll put the graft. If I found that already the sclera is melted, of course, what I will do, first time I'll try to tie the flap 1 time or maybe twice. But if I found with the time that it's not working, I will not keep him for a long time. I had experience with one case when I was resident, actually, long time ago. This patient, he had hypotony post-glaucoma surgery, 6 months. And the macular folds, they were chronic. Even after that, he has been operated and his pressure raised, but he kept actually this folds and his vision never improved. So I don't think so that we have to leave them for a long time. This patient, he has chance. Seriously, he's lucky. I wasn't expected that it will work really 2 months after the surgery, because he came 8 months post his first surgery.
Yeah, this is great management, of course. And you are lucky, and the patient is lucky that you decided to open and to see. Yes, but the point is that what I meet in practice, definitely Express is not commonly used nowadays. I think that there is an era for the Express, and this is not the era for Express nowadays. And what I saw actually is rather of scarring around in the subconjunctival space that I have to go for needling. But I saw express valves protruding through the conjunctiva in the kids, which I don't think is a safe option for the kids to put. And what I saw, and one of our colleagues have shown us an eye with two express on the surface of the globe. That was like a crime, I think so. So I think basically that the scleral flap designed for the express has to be a thick one, because it tends to erode the way that happens in your case. And I think that was an intelligent solution, that to put another sclera for the sclera that dissolved. But again, my impression that a thick sclera is really important in those eyes. And that's really a great management, Umnaya. Thank you very much.
Thank you so much. Yes. Yeah, actually, I have two questions I want to share to ask you, as all of you are here now, about the neovascular glaucoma. Nowadays, actually, most of the patients here in UAE, or the glaucoma patients I'm dealing with, they are neovascular glaucoma. This is the most. I didn't used to do that when I was in Europe. You know, it's a little bit rare than in the Middle East. And all the patients are so complicated. So I have been like trying with many patients different techniques. Some patients I'm doing for them the valve, and some patients I'm doing for them the trabeculectomy. As I've been also worked in France, so it's not the school of the valves. It's more the school of the trabeculectomy more than the valves. But here I found myself that no, I have to deal with both, because our patients, they are so aggressive. The neovascular glaucoma here is so aggressive. I would like to ask you about one point. I started to do it recently, as I have many patients. I start to inject anti-VEGF subconjunctival and the bleb. I had one of my colleagues actually from Brazil. He's glaucoma surgeon as me. So he told me, yeah, let us try this. It will work. Seriously, I didn't find really that really outcome. I found that the patient who had PRP before surgery, or they are lucky to have really full PRP, they are doing much more better than the others. This is my own impression on my patients.
You're absolutely right.
But still, I'm trying injecting the anti-VEGF subconjunctiva. I don't know if you are having this experience.
So that you are thinking like an anti-scarring agent, or like an anti-proliferative for the diabetic retinopathy. Because look, that's why I congratulated Dr. Jalal when he said that removing the ischemic focus is the main treatment option. And you have touched a very critical point, Umnaya, is that PRP is the main treatment for neovascular glaucoma. Up to the extent I tried to do a search for the preferred practice pattern and the large meta-analysis, and I found something very interesting, that there is no absolute proof for the advantages of the anti-VEGFs in neovascular glaucoma. Imagine that. So that you can use that if the eyes are very furious and the neovascularization are aggressive, but you have an eye with some new vessels on the iris and you have a good access to the retina, then you have to go for PRP, definitely. And then once PRP is completed, I think all the options are really good. Whether trab with anti-metabolites, and then you prepare yourself that you will work on it. Might be some needling, you might add some medications, whether valves, so they can work. But the point is that to treat the pathology, and that's why I felt that message from Dr. Galal was really great. And this message is not related to the anti-VEGFs, because anti-VEGFs are really short-acting. Now, when you do trab, then you are doing injection of anti-VEGFs just subconjunctival without trab or with trab, Umnaya?
No, only with the trab. If I choose
only with trab, yes. It is just, so they are used as being an anti-scarring agent, and they are used in trab as well. But I think the reputation of mitomycin is so superior in this area.
Yes, I'm using actually, I'm doing everything. I'm injecting the anti-VEGF intravitreal course pre-op for all patients, And I'm using the mitomycin for all of them. But recently I add this anti-VEGF also and the bleb if I'm going for trabeculectomy.
You have to study it, but the point is that I'm not quite sure that the intravitreal anti-VEGF is the standard for treatment. If you can see the fundus, please proceed for PRP. The point is that when you inject anti-VEGF, there are still some risks for something, because if you are going to do like paracentesis, you can get hyphema, for example. When you are going to inject an eye with very high IOP, and then you are a bit afraid at that time. But the point with PRP that it's usually done on more than one session because the cornea gets dematous during the treatment. But I think if I see the retina, I will go for PRP without injection, even intravitreal and subconj. You might investigate this.
Some of the patients, they refuse to go for surgery, and I found those patients who had the chance to have PRP, their pressure anyway with the time, it will be controlled with medications. Yeah.
Dr. Galal might add something. He's here. Dr. Galal, I think. Dr. Galal, unmute yourself. Yes.
It's okay? You can hear me?
Yeah.
That's okay. Then it's timed. It's usually timed
9 o'clock.
3 to 4 weeks after PRP and 1 week after anti-VEGF to do some surgery. And for mitomycin, you know that it is a longer duration with mitomycin in this type of cases, and we must use it in a subconjunctival and subscleral space. It's better to potentialize the effect. And I agree totally that anti-VEGF and PRP, performing PRP, when I can do a good PRP, I'm feeling good for the patient, and I do anti-VEGF one week before surgery. And PRP, and I decide to make surgery 1 month after PRP and 1 week after anti-VEGF. And when I use mitomycin, it's for longer duration and in subconjunctival and subscleral space. That's it.
Interesting.
So you don't think so that it's really could add something if I'll inject the anti-VEGF in the bleb?
No, I never tried. I tried it.
Complementary anti-scarring. You might investigate this point that use only mitomycin or mitomycin with anti-VEGF. It's a good question to answer, but the point, the retina has to be stable.
True.
That's it.
They are using the same technique Omnia in Morphil Eye Hospital. Dr. Ahmed Al-Armouti, he's injecting in neovascular glaucoma anti-VEGF in the bleb.
Dr. Ahmed Al-Armouti, actually, I took from him the recipe, by the way.
Yes, I know. He's using this in Morphil Eye Hospital for more than 2 years now, and he's collecting patient and data.
Yeah, I will ask him now.
Interesting.
Yes, I know.
So I think it's with this very, very interesting talk and discussion, we will close this this webinar. I would like to thank all speakers. Thanks for sharing your interesting cases. And thank you, dear Dr. Ashraf, for the idea of this meeting. You are the initiator of this idea. And finally, thanks for a special thanks for our partners, Sotema, for their support. And I let Dr. Ashraf Armia to close this webinar.
I must thank you, Dr. Sidi, because as we are talking together about the idea that we make one webinar of cataract and the glaucoma session in one webinar, you agreed on the idea, and we put the topics and the speakers together. So thank you for accepting my idea, and thank you for everyone. It's a great pleasure to meet you all. Thank you so much. Thank you so much.
Thank you very much.
Thank you for all attendees and participants who followed us. I have how much? We have about 1,700 views on YouTube.
This is great.
Right. For now,
congratulations for everyone. Yes.
Congratulations, very nice.
Thank you. Thank you very much.
Thank you
See
so much for everyone. Thank you.
Have a good iftar for everyone, for Shahiyya Tayyiba and Ramadan Kareem, and see you later, inshallah.
Thank you, Dr. Thank you
very much.
Thank you.